So, really lovely to be here. I don't know if we can have the presentation. I'll stop the clock anyway. Oh, thanks. The story behind this is that in 2016, the then regional director of Europe, Susanna Jacob, called me on about the 23rd of December and said, we are presenting to our member states on the impact of our 5-year health and wellbeing strategy, of which equity and leaving no one behind was at the core. And I need a tool that helps me to say what progress we're making and also to be able to engage with policymakers and politicians to advance the agenda. So the work that I'm promoting today is from that work from 2016. The first report was in 2019 and the new report will be launched on the 7th of September. These are the kind of figures that you see in all of the other slides. I'm not going to dwell on it in terms of a difference between men and women, highest and lowest income groups across Europe. And just for Europe, we have 53 member states in the WHO European region, covering the Central Asia, right down to Western Balkans, up to the Nordics, and across to Western Europe. So, as we've heard, health hasn't improved for everyone, but fragility is increasing within countries, and we can see both the men and women for indicators of well-being like self-reported health, mental health, and illness. You're likely to have twice as much illness if you're in the bottom 20% compared to the top 20%. And you can see there the kind of annual cost that has for the EU. What's explaining it? So we have 133 indicators and we use decomposition analysis to help us to identify what are the main drivers of those figures. Statistically significant are the 5 factors on the left, which is access to and quality of healthcare, quality and security of housing, and the safety of neighbourhoods, financial insecurity, and particularly not being able to make ends meet, using probably 2 or 3 jobs, but not making ends meet, lack of trust in others or in institutions, not feeling that you belong, not having access and quality of education and lifelong learning, and then lack of decent work and poor working conditions. And you can see that different age ranges from 16 to 75 plus, the relative importance of those factors in explaining inequalities. And that helps us then to have conversations with politicians and policymakers really about where they're spending their money, what activities are working, and what things to move on from. So in the new report, we decided to take a look at what's happening at every stage in the life course, with the view that it's no point waiting until we get to 65 to try and do something about inequalities. We can do something at every stage of every life course to turn around that trajectory. And here we can see some of the data behind that. So for children before they attend school, twice as high risk of dying before the age of 5 in the east of our region. And for all of the region, we can see therefore indicators of well-being for young children before they're at school in terms of how well they feel. We already see at that age a difference between children from families who are struggling and children living in families who are better off. And you can see the difference already at that age between boys and girls. So we just picked out some of the things that we know are really key. So children and adolescents, this is then when they get to school. Bullying is higher in children in families who are struggling. 28% compared to 31% for girls, 26 to 31 for boys. And also there's 50% less participation in early childhood education and learning for children from poorer families. So already you've got 2 factors here that are explaining sense of fragility. And then we see that there is a definite issue around children going hungry to school in the morning and missing breakfast. So girls and boys from families who are struggling skip breakfast more often and often go to school hungry, and girls more than boys. So the good news is we can do something about that because this works. So we can get a 50% reduction in poverty for children through protected social transfers and family welfare. So This is actually from countries who are doing it, where we can see the results over a 4 to 8 year time period. So it is doable within political cycles or acceptable political cycles. But I think somebody said earlier this morning that there isn't one single intervention. It's no good thinking that for that degree of inequity, that one single intervention is going to work. We need a basket of interventions. And here is the basket of interventions that, from our evidence, says that this will have a double effect. It will improve the health and well-being of every child, but it will accelerate the rate of improvement for children who are struggling or born into families who are struggling. And then you see that we have an 8 times return of that investment over that person's lifetime. And that return accrues to the individual in terms of their own welfare and well-being and health, but also accrues to wider society. Now, what we've seen for the first time, which we didn't see in our first report in 2019, is the number of young people who are struggling and in poverty who actually have physically diagnosed health conditions that prevent them from participating in education, training, and employment. It's twice as high amongst young children, young men and women who are struggling, and you can see that on that chart there. What's driving poor health? Quite interestingly, lack of trust in others. Young people on average have low trust in others, 60% less trust in others. And we see that this is different in different parts of the region. So again, it's a region of 53 member states. It's not one size fits all. And here we can see that particularly for young women living in Central and Western Asia, trust in others, and that's trust that I'm going to be able to live a life and prosper, is very low. We see that there's a range from 4 to 58% and 4 to 26% in terms of young women and men not in employment, education and training. And we've heard how being disconnected from the labour market, from training, from social engagement is bad for mental health, but it's also bad for physical health. And you can see again the gender difference there. And then this was really interesting, the unmet need for healthcare amongst young people 16 to 28. Not surprising for health services, they don't necessarily think of that age range when they're designing the services, in what's in the services, how they're offered, who offers them. And particularly this report relates to mental health. So what we see there is that young women and young men have got something like 2.6, 2.7 times more likely to have unmet need for healthcare, even at that age in life. But a 10% improvement in improving the health of those young people, so the investment that we would make in those services, would release a dividend, and that is 2.6% increase in young women in employment and 1.7% increase in young men in employment. So when we're talking about human capital, social capital, fiscal stability, labour market stability, these are things that we're talking to central banks, finance and economy about, they're interested in. In the working years, we hear a lot about anxiety and depression, but I think these figures even shocked us. You can see there that men and women of working age who are struggling to make ends meet. For a woman, 2.5 times likely to have depression and anxiety compared to the better off counterparts, and for men it's 5 times. And you see it varies across different sub-regions in Europe, but so you can see that in Northern Europe for men there's a massive gap, whereas you can see for women there's a bigger gap, but for men the gap is bigger. What does this look like in terms of cost? So it's not just cost to individuals or their lives or their families, but we can see that it costs EU countries more than 4% of their GDP. And the total cost of depression and anxiety is estimated at 1.36 billion. It has an impact on growth in terms of productivity, early dropout from the labour market, but also in terms of government budgets and fiscal stability. So what's driving that? I'm sorry, the arrow's on that sheet, but excess working hours. So doing 2 or 3 jobs and working excess hours is one of the main causes of stress and anxiety. Low levels of control over life, and that's to do, the two things are related in terms of spending all of your time at work, still living in poverty and not having a sense of control. And also we found with the COVID that what this group, working age population, feel is that they're working, they're doing 3 jobs, they're paying their taxes, but the government policies are benefiting other people but not them. And this is one of the reasons where we're seeing lack of trust, radicalization, and political extremism coming into the fore. Not meeting family and friends, twice as likely to have a loneliness and isolation if you're in if you're a poor man and a woman, and this also has an increased risk for depression, earlier cardiovascular disease as well. What's leading to that? Well, some of it is poor financial decisions with dire consequences. So government spending as a percentage of GDP on wages and social protection has decreased in nearly a third of European countries. Out-of-pocket medical expenses have increased in nearly half of the region. So what we've got is shifting the financial burden of healthcare onto households has increased the number of men and women with unmet need for healthcare, as you can see there, and increased risk of poverty. So those financial decisions have an impact even within the short term. What we're seeing is much more employers, small businesses, large enterprises, reaching out and working with health sector, occupational health and workers to ensure that people don't fall out of work due to poor health and poor working conditions. And if they do, they quickly get back into decent work and working conditions. And here we can see the impact of integrative policies, active labour market policies that include all of those elements. They improve the well-being of all workers. So it's a win-win for everybody, but you see the accelerated improvement in health and outcomes for those who are falling behind. So what we can see is smart investments in public health policies during working years. Benefit now. We don't have to wait to get those benefits, and reduce the risk of poverty over 65. And you can here see some of those results there. What we're not showing is a chart here on acting around pension security for women, particularly between the ages of 50 and 65. What we can see with that, it actually reduces poverty rates of women by 50% after they retire between 65 and 80. So if you're looking where to invest, that's a good outcome, given that women live longer. Is it possible to live well after retirement in Europe? Okay, we expect some limitations as we all get older, speaking for myself. But here we can see 40% more limitations to life for older men and women who are struggling with poverty, and you can see the gap there between the top and the bottom. What are the factors driving that? Loneliness and social isolation. Older men and women are 3 times more likely to experience loneliness and social isolation, poverty, and we can see that these have a direct impact on a 50% higher risk of stroke and dementia. Unmet needs for healthcare, particularly local healthcare that's relevant where people live, and you can see the poverty factors there. One of the big things that's contributing to older age health problems and inequities is living in poor quality and unsafe homes. So older people who are struggling to make ends meet, 3 times more likely to live in uncrowded, unsafe homes. So higher risk of falls, higher risk of respiratory. And also there's another aspect of unsafe homes is that people living in areas where they are frightened. So living in fear, fear of violence in the home, but also fear of violence in the local neighborhood. What's possible? So in fact, there's been quite a splurge of innovations in new approaches to local health and ecosystems. And we can see through expanded models of primary and community care, social prescribing, which are beyond paying for going to a gym, which are really rooted in local communities. We've seen that in the UK and in Belgium, where they've been implemented as a whole system, it's reduced emergency hospital admissions by 30%, and it's actually increased the confidence of self-managing chronic conditions by 80%, and a huge reduction in loneliness. There is something else that matters, and I alluded to it earlier when I was talking about trust. Social participation and the lived experience of people who are left behind in designing policies for them is important. We heard this morning about the AI and whether, in fact, people are represented in the data. Here is another thing, it's backing that up here. So where people participate locally, where there is a means for them to participate, where the local governance engages the public, informs the public, involves the public in service design and review, we get higher life expectancy. It's as simple as that. This is probably my last slide, so I'm a little bit before time, but this is a summing up, and this is some modelling that we did, because one of the challenges we found with inequities when we're talking to politicians is, yeah, well, you know, can it be done? Yeah, okay, but can it be done while I'm still in power? It can't be done within 4 years. So we did some modelling to say that with a affordable investment in these 3 basket of policies, that within 4 years in a country of 80 million, it can improve 300,000 lives. So our politicians have been in the Italian Parliament quite a lot recently because of things like this. So this kind of stuff is helping us to move the agenda forward. Thank you.